Hi, I'm Dr. James Amos. I'm a consulting psychiatrist at University of Iowa Hospitals and Clinics in Iowa City, Iowa, and this is yet another Geezer video, and this is a dirty dozen on cognitive behavioral therapy. I did an earlier dirty dozen on the common elements in psychotherapies, and this is an extension of the subject. It's best to probably view this on my blog site, The Practical Psychosomaticist, at jajsamos.wordpress.com. Where you can view the commentary, a very nice video by the Aaron Beck Institute, interviewing Aaron Beck himself, the architect of cognitive behavioral therapy, and annotated slides as well. So as usual, I'm going to go through the slides here. I have less than a dozen of them. We'll go through them fairly quickly. This is not intended to be an exhaustive review of CBT, of course. It's a very vast subject. But a brief overview and an introduction with some resources at the end that you can view. There'll be web links to important websites, in my opinion, for you to look at in order to learn more about CBT. I also am going to read a selection from a book that Dr. Robert G. Robinson, a colleague of mine, and I co-edited. The book is Psychosomatic Medicine, An Introduction to Consultation Liaison Psychiatry. And this is the book, Psychosomatic Medicine, published in 2010 by Cambridge University Press. And the chapter is written by a couple of colleagues of mine, chapter 27, Psychotherapy for the Hospitalized Medically Ill Patient, written by Scott Temple, PhD, and Scott Stewart, MD. CBT for health problems is based on the assumption that cognition mediates emotional and behavioral responses to medical illness. CBT dovetails with ancient wisdom traditions, which teach that it is not what happens to a person, but his or her interpretation of what happens that is critical. Depressed thinking is often reflected in what Beck described as the cognitive triad, which consists of negative, automatic thoughts about the self, I'm a loser, the world, nobody cares about me, and the future, I will never amount to anything. Anxiety chiefly consists of overestimations of threat and an underestimation of one's ability to cope with real and perceived threat, as well as with an uncertain future. Anxious cognitions in the medically ill might include the following: I can't stand getting an operation, I'll go nuts. Or, I'm going to die, I just know it. Or, I can't cope with injections. This stream of painful thinking is often unnoticed and unchallenged by the patient. Such thoughts, which Aaron T. Beck, MD, the founder of cognitive therapy, described as automatic thoughts, are accessible to patients once they are encouraged to tap into the stream of thoughts and visual images that occur in emotionally charged trigger situations such as occur during hospitalization. Thus, automatic thoughts serve as a form of private communication, are highly believable, and exert a profound influence on emotions and on behavior. By encouraging the patient to share with the consultant the stream of private automatic thoughts, the consultant can sometimes quickly learn to unlock seemingly puzzling symptoms of depression and anxiety. Common treatment strategies include the use of mood logs and thought records. This might involve asking a hospitalized patient to rate mood on an hourly basis and to chart his mood during the day to find variations. Such variations may reveal trigger situations for distorted cognitions, or may reveal difficulty coping with painful medical procedures and other stressors present during hospitalization. Patients in CBT are taught to examine their thinking for repeated biases, such as in the cognitive triad or the cognitive features of anxiety, and to create alternative, more adaptive ways of viewing themselves and their circumstances. Rooted also in behavior therapy, CBT encourages the use of adaptive coping strategies and may foster the development of new coping skills or communication skills as deemed necessary for the patient. It's an excellent book. I'm allowed to plug my own book. There are a couple of other books that this presentation is also based on, and of course the one that I mentioned previously in the common elements of psychotherapy, The Art and Science of Brief Psychotherapies, A Practitioner's Guide, and that's this book. And there actually is a new edition of this published in 2012, so you'll probably want to look into that. It also has a DVD associated with it, the same as this book, Learning Cognitive Behavior Therapy, an illustrated guide, edited by Jesse Wright, Monica Basco, and Michael Face. And this is this book. It's a book worth checking out. It's very readable, and it was published in 2010. And I have recommended, believe it or not, Cognitive Behavioral Therapy for Dummies. And this is what it looks like. It's a big yellow book, just like any other big book for dummies. And I'm not calling anybody a dummy. I'm just saying that this is a book that has been well reviewed. It's very helpful. I've read it myself, and I think it's a great introduction to CBT. There's also a new edition of this book published in 2010. It's a second edition, also by Rena Branch and Rob Wilson. So we're going to start with slide 3, the origins of CBT, and as I've already indicated, it was originated by Aaron Beck. The psychoanalytic theory in psychotherapy was dominant in the 1960s, and Beck, who was the creator of CBT, was trained as a psychoanalyst. He conducted experiments with others in the late 1950s and early 1960s, intended to support psychoanalytic sorts of constructs, and compared them with cognitive behavioral therapy types of constructs. While they expected psychoanalytic constructs to be superior, the opposite was found to be true. So, as an example, depression was thought of as anger directed inward, and that actually was found to be a less accurate paradigm of what happens in depression than negatively biased judgments that patients had of themselves, particularly negative thoughts about themselves, their world, and their future. Some definitions and assumptions on slide 4. Focused therapy that is based on a model that psychological disorders involve dysfunctional or unhelpful thinking. Some authors prefer the term unhelpful thinking rather than dysfunctional thinking, and that would be Chris Williams, and his references are also included in the reference list at the end, and I'd encourage you to look at those. It's also based on the notion that we often feel what we think and behave accordingly. It assumes that modifying dysfunctional thinking improves or resolves symptoms of depression, anxiety, and so on. And also that modifying dysfunctional beliefs, underlying beliefs, underlying dysfunctional thinking produces more sustainable change. A sort of overview of CBT. It's a pragmatic, action-oriented treatment approach. It was initially developed for depression and anxiety, but has been applied to many other types of disorders. It's an empirically validated, brief psychotherapy that has been shown to be effective in well over 350 outcome studies. It's effective in the treatment of physical symptoms such as chronic fatigue, hypertension, fibromyalgia, cancer, or depressive symptoms and anxiety associated with cancer, diabetes, and a wide variety of psychiatric conditions, including, but not limited to, major depression, panic disorder, and even schizophrenia. It gets at the two-way relationship between cognition and behavior, posited in which cognitive processes can influence behavior, and behavioral change, it's a two-way street, can influence cognition. The next slide is about what you often hear about in CBT, which are automatic thoughts and maladaptive schemas. Automatic thoughts take the format of self-statements, like, oh, I should be doing better in life. I've let him down, or I can't handle it. Maladaptive schemas are sort of the filters that we build up over the course of years in terms of our experience of life in the world and with others. And they're again, self-statements like, oh, I'm unlovable, I'm a fake, I must be perfect to be accepted. And those are the types of things, that kind of bedrock filter, that we seek to change in CBT ultimately. Key behavioral concepts to keep track of to get a better understanding of CBT are that depressive behavior can be modified with behavioral techniques. You don't necessarily have to start with the so-called dysfunctional thinking. Exposure therapy and related interventions can be effective for different types of anxiety disorders, including obsessive compulsive disorder. Behavioral interventions can be useful for helping patients improve their coping, their social interactions, and problem-solving skills. Some fundamental principles of CBT is next. The overall goal, of course, is to help achieve remission of psychological disorders or interpersonal problems by solving them through a process called collaborative empiricism, which is a form of working together between therapist and patient to engage a person in learning how to solve his or her own problems with behavioral experiments. It's an approach which teaches patients to view reality a little more clearly by examining their own unhelpful thinking, and thereby making it possible for them to correct faulty ideas that lead to improvements in mood and function. It's educative in nature, and it teaches patients to be their own therapists. It's very practical and goal-oriented. Just touching on CBT methods such as Socratic questioning, which you may have heard of. It's a type of questioning that is not didactic. It doesn't give you all the answers or spoon-feed you. It stimulates curiosity by asking questions in a way to engage the learner to try answering questions for themselves. The guided discovery method is sort of a form of Socratic questioning. It's a series of inductive questions to reveal unhelpful thought patterns or behaviors. Examining the evidence and identifying certain types of cognitive errors they are also examples of methods used in CBT. Role play and rehearsal can also be done, and that can be a very powerful way of demonstrating to people what they're doing in real life, in their own lives and at work. Behavioral methods that are used in CBT are things like activity and pleasant event scheduling, graded task assignments, and relaxation training. Well, the next two slides are the last two, as usual, references. Well, I hope you enjoyed this. We've gotten through it fairly quickly, and as I indicated, it's just an overview, something to whet your appetite to learn more. And if you have questions or comments, please drop them off at the Practical Psychosomaticist. Good luck.